Okay. So the tag we got cited for our plan of correction here is F686, quality of care, treatment and services to prevent and heal pressure ulcers. The intent of this requirement is that the resident does not develop pressure ulcers or injuries unless clinically unavoidable, and that the facility provides care and services consistent with professional standards of practice to promote the prevention of pressure ulcer and injury development, promote the healing of existing pressure ulcers or injuries, and prevent development of additional pressure ulcers. The facility must place priority on identifying what each resident's highest practicable well-being is in each of the areas of physical, mental, and psychosocial health. Each resident's care plan must reflect person-centered care and include resident choices, preferences, goals, concerns, needs, and describe the services and care that is to be furnished to attain or maintain or improve the resident's highest physical, mental, and psychosocial well-being. Prevention of pressure ulcers and injuries. A pressure ulcer or injury can occur whenever pressure has impaired circulation to the tissue. A facility must identify whether the resident is at risk for developing or has a pressure ulcer upon admission and thereafter. Evaluate resident-specific risk factors and changes in the resident's condition that may impact the development and/or healing of a pressure ulcer or pressure injury. Implement, monitor, and modify interventions to attempt to stabilize, reduce, or remove underlying risk factors. And if a pressure ulcer or pressure injury is present, provide treatment to heal it and prevent the development of additional pressure ulcers or injuries. The first step in prevention of pressure ulcers or pressure injuries is the identification of a resident at risk of developing. This is followed by implementation of appropriate individualized interventions and monitoring for the effectiveness of the interventions. Assessments. An admission evaluation helps identify residents at risk of developing a pressure ulcer and residents with existing pressure ulcers. Because a resident at risk can develop a pressure ulcer or injury within hours of the onset of pressure, the at-risk resident needs to be identified and have interventions implemented promptly to attempt to prevent pressure ulcer or pressure injury. The admission evaluation helps define those initial care approaches. In addition, the admission evaluation may identify pre-existing signs suggesting that tissue damage has already occurred, and additional tissue loss may occur. For example, a deep tissue pressure injury identified on admission could lead to the appearance of an unavoidable stage 3 or 4 pressure ulcer. A stage 1 pressure injury can progress to an ulcer with eschar or exudate within days after admission. Some situations which may have contributed to this tissue damage prior to admission include pressure resulting from immobility during hospitalization or surgical procedures, during prolonged ambulance transport, or while waiting to be assisted after a debilitating event such as a fall or a CVA. Examples of risk factors: impaired or decreased mobility and decreased functional ability, comorbid conditions such as end-stage renal disease, thyroid disease, or diabetes, drugs such as steroids that may affect healing, and impaired diffuse or localized blood flow, for example, generalized atherosclerosis or lower extremity arterial insufficiency. Resident refusal of some aspects of care and treatment, cognitive impairment, exposure of skin to urinary and fecal incontinence, undernutrition, malnutrition, and hydration deficits. And the presence of a previously healed pressure ulcer or injury, the history of any healed pressure ulcer or injury, its origin, treatment, its stages if known, is important assessment information, since areas of a healed stage 3 or 4 are more likely to have recurrent breakdown. Adequate nutrition and hydration are essential for overall functioning. Nutrition provides vital energy and building blocks for all of the body's structures and processes. Any organ or body system may require additional energy or structural materials for repair or function. The skin is the body's largest organ system. It may affect and be affected by other body processes and organs. Skin condition reflects overall body function. Therefore, the presence of skin breakdown may be the most visible evidence of a health issue. Both urine and feces contain substances that may irritate the epidermis and may make the skin more susceptible to breakdown and moisture-related skin damage. Fecal incontinence may pose a greater threat to skin integrity due to bile acids and enzymes in the feces. Irritation or maceration resulting from prolonged exposure to urine and feces may hasten skin breakdown, and moisture may make skin more susceptible to damage from friction and shear during repositioning. Prevention and treatment. Based upon the assessment and the resident's clinical condition, choices and identified needs, basic or routine care should include but is not limited to interventions to redistribute pressure, such as repositioning, protecting and or offloading heels, minimize exposure to moisture, and keep skin clean, especially of fecal contamination. Provide appropriate pressure redistributing support surfaces and provide non-irritating surfaces, and maintain or improve nutrition and hydration status where feasible. Adverse drug reactions related to the resident's drug regimen may worsen risk factors for development of or for non-healing pressure ulcers or injuries. For example, by causing lethargy or anorexia or creating increasing confusion and should be identified and addressed. These interventions should be incorporated in the plan of care and revised as the condition of the resident indicates. Repositioning or relieving constant pressure is a common effective intervention for an individual with a pressure ulcer who is at risk of developing one. Resident or assessment of a resident's skin integrity after pressure has been reduced or redistributed should guide the development and implementation of repositioning plans. Such plans should be addressed in the comprehensive care plan consistent with the resident's needs and goals. Repositioning is critical for a resident who is immobile or dependent upon staff for repositioning, as a resident is unable to make small movements on their own that would help to relieve prolonged pressure to one area. The care plan for a resident at risk of friction or shearing during repositioning may require the use of lifting devices for repositioning. Positioning the resident on existing pressure ulcer should be avoided since it puts additional pressure on tissue that is already compromised and may impede healing. The one thing, like when you guys are on the floor, I've been encouraging is the maxi slides. If somebody is too heavy where you cannot do it safely with the two-person pulling them up without their skin sliding against the sheets, then we should really encourage the use of the maxi slides. I'm being told like One North, we only use it on one person. A lot of people do decline, but we really should encourage that. It will help some of these shearing injuries. Repositioning, determine frequency with consideration to the individual, their level of activity and mobility, their general medical condition and overall treatment objectives, skin condition and comfort. And as the nurse, you need to really determine, is the Q2 hours repositioning enough for that person? Do they need to be a Q1 hour? How bad is the wound? Are they able to make small adjustments? So you have to kind of look at that resident as a whole. We have reviewed and made some updates to our skin policies, so I'm just going to touch on the highlights on some of them. Pressure injury prevention and management. Skin integrity checks are to be completed twice per week on all residents by a nurse. All skin checks will be recorded as completed in the EMR, and any issues will be documented in the interdisciplinary notes and reported to the unit manager. Resident will be assessed from head to toe, including all skin folds. Complete the assessment without the resident wearing clothes, including taking off their socks. Adequate privacy must be provided. If a newer skin or wound problem is found during the skin integrity check, the nurse will initiate a separate documentation note and notify the nurse manager and the physician. The nurse will initiate a treatment for the skin or wound problem if appropriate. And then also, I've just been making sure that everybody knows if it's a pressure ulcer, it needs to go on a pressure ulcer care plan. If they don't have one, they need one. All skin issues, though, go on the skin integrity care plan, and I have been making sure that I'm letting them know that as well, all the nurses, just so that if a new one's found, it can be immediately put on. Wound vac system, we are going to have some upcoming wound vac training dates that will be coming very soon. Carrie Valancourt is working on getting those set up, just in case we do have a wound vac, because we did have a resident that was going to have one. But just, I would recommend that you always have 2 when you do a wound vac, because as you know, it's really hard to get the drape on with gloves on by yourself. But you want to ensure that the vac drape is used to cover the vac foam dressing with an additional 3 to 5 centimeter border of surrounding tissue so that it can really suck into the wound and cover the whole wound. Drape may be cut into multiple pieces for easier handling. Choose a site for your trackpad application. Pick a site that allows the most flow and not over a bony prominence. Obviously, you're going to have a tube coming out of that goes to the container. So you're just going to want to make sure that you position it as best as possible to try to not have the resident lay on that if all possible. Attach canister to the vac therapy unit and lock it into place, and turn on power to the vac therapy unit and select the proper settings. Dressing should be maintained for 48 to 72 hours. Typically, they're changed every 3 days. That's usually what we see, and they're usually the settings are 125 is what they always usually start with. Wound treatment management. Wound treatments will be provided in accordance with the physician order, including, okay, so this is one thing that we're really trying to work on during our skin meetings to update our orders, but all orders, it can't just say apply a Mepilex every 3 days, okay? So you have to have the cleansing method. Are you cleaning it with wound wash, normal saline? You're gonna pat dry. You're gonna apply, let's say, calcium alginate, and you're gonna cover it with a Mepilex. We're gonna change it every 3 days in PRN. So all of that needs to be in your order. There also needs to be a PRN order attached to every single order, because it might say PRN, but there's not an actual PRN tab to where people can sign it out. So the PRN order needs to be including in all treatment orders to be utilized if dressing changes need to be completed in between their ordered frequency, in case the dressing comes off. Use the wound treatment guidelines in the binders at the nurse's station to assist you with order selection with the physician. Treatments will be documented on the TAR. I also was letting everybody else know, try to use that as a guideline if you're not sure, especially if you find something in the middle of the night. It's better to put something in place than nothing at all. And if you're unsure, you can send obviously one of you guys managers, an email, or we can check it when we come in, make sure it's appropriate. If it's not, we'll change it at that point, but we definitely have to initiate something. A full body or head to toe skin assessment will be conducted by the nurse upon admission, readmission within first 4 hours, as ordered twice per week, LOA from facility, or after extended overnight LOA visit. The assessment may also be performed after a change of condition or after a newly identified pressure ulcer. One thing I'm really big on, and I've been really trying to make sure that everybody is aware, I also expect if it's like a late evening admission for the unit manager, the next morning to come in and do a second set of the skin, a second peek at the skin, so we make sure that we're taking credit for everything that is on the body. Pay close attention to pressure points, bony prominences, and underneath medical devices between fingers and toes and abdominal folds. Obviously, if they just have redness, put something in place so that we can prevent it from progressing. Nursing assistants shall inspect all skin surfaces during bath or shower and report any concerns to the resident's nurse immediately after the task. Nursing assistants shall also report change in skin condition that are noted during any care procedure. Notification shall be made to the nurse verbally or in writing. They cannot complete your skin assessments for you, though. You have to complete them yourself. Provide and encourage adequate daily fluid intake. Routine repositioning schedule every 2 hours using both side lying and back positions. Reposition when in bed and out of bed. Utilize maxi slide to reduce shear and force and avoid dragging the resident when repositioning. Avoid positioning the resident directly onto a medical device. When turning to a side lying position, do not tilt the head more than 30 degrees as it causes pressure to the sacrum. Ensure that heels are floated off the surface of the bed using pillows or devices that elevate and offload the heel in such a way as to distribute the weight of the leg along the calf without placing pressure on the Achilles tendon, and minimize seating time out of bed time to promote ischial and sacral wound healing. If somebody has a coccyx or a sacral wound or an ischial wound, they really shouldn't be getting up at 4:30 a.m. and sitting in their chair until it's breakfast time. It's too long. They really shouldn't be in their chairs more than 2 hours, long enough to get up right before meals, to eat, and back down, so they're not causing so much pressure. If you're noticing that heels cannot be floated with a pillow or multiple pillows and it's still causing a problem touching the sheets, let us know so that we can get a heels up device or something along those lines. Wound photo documentation. I did get you little handouts here, and this is just to help you along the way in case you need any assistance. Use the ghost function though, that's what we're asking, so it's the same angle as the prior picture, same distance away, just so we're getting accurate pictures. Only nurses will photograph wounds. CNAs are not allowed to photograph the wounds. And if you need more training on the use of the photography of the wound phone, please let me or Carrie Valancourt know and we'll give you further training. For subsequent photographs, techniques to ensure consistency will be utilized the same vantage point from the same angle, left or right, approximate distance from the room, and the same image size on the digital camera. No wound shall be photographed using a personal cell phone or other internet-connected device. Concerns during resurvey. A resident was readmitted to the facility on 1/18/22, and skin assessment that was completed did not include all skin issues. Only indicated 2, when wound clinic documentation indicated 7. During dressing change observation, did not sanitize table before placing drape barrier. No dressing was in place when it was attempted to be removed, and a dressing was to be in place at all times per order. Nurse applied Santal to the wound bed with a soiled gloved finger instead of a cotton tip applicator. Nurse removed gloves and did not perform hand hygiene before reapplying gloves. Applied skin prep with no gloves on. During the dressing change observation, the nurse removed gloves and did not perform hand hygiene before using wound phone. Nurse applied a Mepilex to the wound and then dated and initialed the dressing while on the resident with a marker. Nurse placed marker back in her pocket without sanitizing it. Resident was supposed to be wearing an incontinent brief. Nurse left the room without applying a brief to the resident. Wound clinic notes from 1/19/22 indicated 2 new areas, but skin assessment on 1/19/22 did not indicate any new areas. Care plan did not reflect all skin areas. Hi. Copies of competencies will be kept at the nurse's station for you. When doing measurement, length and width and depth need to be included. Depth needs to be manually entered into the assessment phone. So you need to use a cotton tip applicator, use your marker, put your cotton tip applicator against a measuring tape, and you need to enter the depth.